अस्सलाम वालेकुम व्यूवर्स। आज हम देखने वाले हैं हाइडेटिफॉर्म मोल के बारे में। ये क्या है इसका पहले देखेंगे डेफिनेशन। इट इज़ एन एबनॉर्मल कंडीशन of placenta where there are partly degenerative and partly proliferative changes in the young chorionic villi. Yes, this is definition. Abnormal condition of placenta where there are partly proliferative and partly degenerative changes in young chorionic villi. Now, this is a benign condition and it is a type of gestational trophoblastic disease. Now, it is of two types. It can be complete or it can be incomplete. Now, why it is called as hydatidiform mole? Because it looks like hydatidiform cyst of echinococcus. So, it is called as hydatidiform mole. Now, what causes this? We will see etiology. It occurs in extreme of ages, that is pregnancy which occurs in teenagers or when pregnancy occurs above 35 years of age. Extremes of age, that is teenager pregnancy and those above 35 years of age. Now, its prevalence vary in race and ethnic group. Or it also depends on nutrition. That is when the nutrition is faulty, when there is decreased dietary intake of carotene, this can occur. Then when there is disturbed immune mechanism, then it's cytogenetics. We will see it's cytogenetic. In cytogenetic, what occurs in complete and what occurs in partial or incomplete mole. In this, this is ovum and this is sperm. This sperm fertilizes the ovum, but later the nucleus of the ovum degenerates and the ovum's nucleus has been degenerated, but when this sperm fertilized, the sperm nucleus divide by mitosis and leads to sperms, leads to formation of 46XX condition mostly. And what occurs in this partial or incomplete mole? One ovum is fertilized by two sperms. So the resultant zygote will be 64 XXX or 69 69XXX or 69XXY, mostly this one. Now this paternal to maternal chromosome ratio, it is 2 paternal to maternal chromosome ratio, it is 2 is to 0 in this complete mole, and it is 2 is to 1 in partial or incomplete mole. The more the ratio, the higher the risk of its conversion into metastatic disease. The higher the ratio, the more of its chances to develop into a hydatidiform mole. Now, and its recurrence rate are also high. Matlab, if there is previous history of hydatidiform mole, there are chances of its recurrence. Now, its pathology. Mainly, it is a disease of chorion. What occurs in this? Death of the ovum is essential. Death of the ovum or failure of embryo to grow is essential for development of complete hydatidiform mole. Then in this there occurs increased secretion from the hyperplastic cells, and there occurs there are present transferred substance from the maternal blood which is accumulated in the stroma. There is a hyperplasty of this trophoblastic cells, so there will be increased secretion, and this secretion will accumulate, and this will form a cyst like structure. What is cyst? It is a fluid filled cavity, and in this fluid will be present, and this maternal nutrition transferred substance from maternal blood, it will also accumulate. And this leads to distension of our normal villi. Then it can also be due to edema and liquefaction of stroma, and the fluid present in this cyst is similar to the ascitic or edema fluid, but it is rich in HCG because it is a a benign condition arising from the trophoblastic cell, so it is rich in HCG. Now, macroscopically, it is like a mass which fills the uterus. Mass filling the uterus. And it is like a chain or cluster of a cystic uh, chain or cluster of cysts of varying size. This is what it looks like, and it fills the uterine cavity. Microscopically, we can see there is proliferation of syncytial and cytotrophoblastic cells. Then there is no blood vessel, and villus pattern we can see on microscopy. Now, what are the clinical features? Vaginal bleeding is the most common feature, most common presentation. Then, due to the stretching of the uterus, there can occur lower abdominal pain. Then, there can occur constitutional symptom, that is, there can occur vomiting. Vomiting, this occurs due to increased HCG. Then, there is breathlessness. Why breathlessness? This trophoblastic cell can embolize to the pulmonary vessels, leading to pulmonary embolism and dyspnea. Then there are thyrotoxic feature. Now we will talk about its sign. As there is bleeding, the bleeding which occur in this is during early pregnancy. The other signs, there is pallor. Then there occurs feature of preeclampsia. Then when we examine abdomen, the features we see: size of the uterus. It is more than expected in 70% of cases, then equal to the expected in 20% of cases, and less than expected in 10% of cases. Then feel of the uterus is doughy. Then fetal movements are not felt. Then on vaginal examination, there is internal development cannot be elicited. Then unilateral or bilateral enlargement of ovary can occur or can be seen. Then if in vaginal examination, if we see vesicles, then it is pathognomic finding of this hydatidiform mole. Then what are the investigation we should do in this case is we should do USG sonography. In sonography we will see snowstorm appearance. Then as we know, HCG is raised, so HCG estimation should be done. rapidly increasing HCG of more than 1 lakh milli international unit per ml is there. Then chest X-ray can be done to check whether there is pulmonary embolization of this trophoblastic cell. Then CT, MRI are not recommended, and definitive diagnosis is done on histology. Now, what are its complications? Complication, hemorrhage and shock can occur. When this vesicle detach from decidua, there occurs bleeding. Then massive intraperitoneal hemorrhage is the first feature of perforating mole. And then bleeding can also occur while evacuating this hydatidiform mole. Then sepsis can occur as a complication, as there is no protective membrane. In normal pregnancy, membranes are present, but in this case, no protective membranes are present, so vaginal organism can creep up into the uterine cavity. Then presence of degenerated vesicle and old blood, this favors the growth of the bacteria. Then there can occur perforation of uterus. If there is perforating mole, or while doing evacuation, perforation can occur. Then features of preeclampsia, then we have seen acute pulmonary insufficiency due to that pulmonary emboli. Then coagulation failure, this occurs due to pulmonary embolization of trophoblastic cell, as they causes the platelet and fibrin deposition. There is decrease of these fibrin and platelets in the blood, and as a result there is coagulation failure. Then for management, suction evacuation, and curettage. We do this suction evacuation and curettage. In supportive treatment, we can give blood transfusion, antibiotic if there is sepsis, and counseling for regular follow-up for 1 year, because this metastatic changes can occur in this only up to 1 year. Now there is a chart given in this datta. We will see that uh, I don't know whether this chart will I will be able to draw this chart in this small space. If mole is ready for expulsion, then if there is inert uterus, we we will see one by one. If mole is ready for expulsion, then we will do suction evacuation, then curettage, and we will ask the patient to follow up after 1 year. Now, if the uterus is inert, there are two conditions. If the patient is young or elderly, young and desire of child, then we will do evacuation. Then there are two possibilities. We can do it vaginal or abdominal. So vaginal is done when there is favorable cervix, there is no other complication. So abdominal is done in rare cases, only when there is bleeding PV which can't be controlled, then if the cervix is unfavorable. We do here is abdominal hysterotomy. In vaginal, we if cervix is favorable, we will do suction evacuation and curettage. Here is favorable. Here is if it is unfavorable, we have to do slow dilatation, then suction evacuation. If cervix is favorable, we will do suction evacuation, then curettage. This curettage is done in selective cases. Now, when the age of the woman is more than 35, or a family is completed, or if there is perforating mole, we will do hysterectomy. In all these cases, we will ask the patient to follow up for 1 year. Now, after 1 year, for 1 year, what we will do, we will check for HCG, now if HCG is not decreasing, that is HCG is plateau or re-elevating, so we should exclude pregnancy, and we should also counsel the patient to not to become pregnant in for 1 year. Exclude pregnancy, then evaluate for persistent trophoblastic disease. And if it HCG level decrease, so it becomes normal in 4 to 6 weeks. Then we will ask the patient for monthly follow-up for 1 year. This was all about hydatidiform mole. Please do like my video if you like my teaching, and don't forget to subscribe my channel. Thank you.